I think the key important flavor that we've been getting in the past few talks is that multimodality treatment is important, not just sort of saying, I'm going to do this and stick with this one item of one mode of treatment, and that's going to be the future. So, when we're looking at laser in isolation, effectively, I'm just going to briefly refer you to a very important document that was prepared in 2014. It's a consensus document on utilization and management of scars with laser and how to involve them in scar management. And the outcome of this was a beautiful flowchart, of which I've only included the bottom half here. But it'll be very useful, because I haven't got too much time in this talk to focus on the various different flow algorithms for management with laser. But if you refer to that document, you'll see where my input is with my scar patients is directed from effectively. So I want to talk a little bit about acne scars to start with, because it's something I tend to manage a lot in cosmetic dermatology. And effectively, Anna Maria was talking a lot there about lasers and comparing things. One of the things that I understand very pertinently with laser is that there are so many different machines and so many different parameters that can be used that standardizing an approach is very difficult. Some people will, when you're doing a retrospective analysis of what was done, in terms of, well, I used this fluence, I used this device. With this device, you get a coagulative zone of 100 microns. With this device, you get one of 10 microns. And all these parameters histologically change what is going on in the skin. So to like for like compare them is almost impossible. So you need to have a lot more agreement between centers with lasers and devices performing studies to perform meaningful studies that give you data that can be compared accurately. And that's one of the key problems in sort of creating protocols and looking at the efficacy from an evidence-based perspective. But let's have a little look about acne scar topography, because the key here as well is just not broadly classifying things. You heard from Yanis there that keloids and hypertrophic scars very often just get lumped together in one bunch, but the factors that are taking place within the actual scarring itself are very different sometimes and require different approaches. So with acne scarring, we have, as you're probably all aware of, we subclassified them into sort of scar phenotypes, such as rolling scars, box scars, ice pick scars. Each one of those scar types is very different. With rolling scars, the inflammatory processes that occurred in the acne pathology that caused the scar to form caused disruption to the subcuticular fat and then caused tethering of the subcutis to the actual SMAS. And when that happens, you get these tethered scars that are very, very difficult to manage. But as Anna Maria mentioned earlier, subcision is a very powerful tool. So we have to not just say, well, let's just laser over everything or let's microneedle over everything. Those modalities aren't going to do anything for fibrous tethering. They're just going to help perhaps a little bit with the intradermal atrophy. So we have to subcise those scars to treat them. So they are quite tough to treat. If we look at these, this is sort of a picture of the type of indentation you get from rolling scars. And it'd be quite traumatic and people feel very, very conspicuous when they have these type of scars and want something done about them. Ice pick scars. Now these are, for me, my nightmare really. They are very, very difficult to treat. Now this scar type is very different to a rolling scar. Effectively what we're dealing with here is epithelial tract formation. So the follicular unit basically has become damaged through the inflammatory process. And it is epithelialized down its length, which basically is very difficult to do something about. You just put a needle into it, and the needle will come straight out. Nothing will have happened to that scar. You laser past it. What are the chances that some of your fractional laser columns have gone into that scar? It's difficult. It's like a sinus in a way. When you have a sinus, you don't just put a needle in, you excise it out and remove it. So you have to remove it. That's how you surgically manage a sinus or a tract. So this, when I see this kind of patient, I think, oh my God, this is going to be a hard one. You know, and it's one of the ones that you really sort of have to struggle with to get somewhere. Box scarring, a little bit easier to deal with because the majority of this damage is intradermal. Box scars are a little bit like the skin has a scaffolding, and someone's released a little mini grenade in that scaffolding, and it's just exploded and caused part of the scaffolding to collapse, but that's only in the superficial part of the skin. So, you know, they can be deep as well, but most often we see the sort of 0.5 millimeters, peri 0.5 millimeters of depth of box scar scarring. And here you go. It's still quite traumatic from a sort of cosmetic point of view. You know, people do not like this type of situation on their face. So, you know, there's a lot of merit and we can do a lot to make this better. Multimodality management is what I was talking about, integrating different treatment methods to get an optimal result. So let's talk about the treatment of those three types of scars. Rolling scars, as I said, my approach to that would be first and foremost to release the fibrous tethering of the scar. Then the actual dermal atrophy needs to be treated, and I treat that with fractional ablative resurfacing. There is very interestingly, as Anna Maria was pointing out, a role for fillers as well, but fillers just don't lift things up. Hyaluronic acid within the dermis has been shown to stimulate the CD44 receptor of the dermal fibroblast and create new collagen. So there is a neocollagenesis associated with filler application as well. And that is what we're looking for in atrophic dermis, to remodel and synthesize new collagen. When I subcise the scars, one of the biggest problems that, you know, speaking to my fellow dermatology colleagues they have with subcision is they say, see, it bleeds like stink. And I say, yeah, you know, if you're going to use a no-core needle, you've probably all seen the 18-gauge no-core needles. These are basically an 18-gauge needle, but it's actually got a micro blade at the end. And if you start poking around with that needle, it's quite a dangerous thing, actually. You could literally plant it a little bit deeper than you want, cause facial nerve damage, cause a whole lot, and not just that, you'll cut through a whole load of perforators as well. And before you know it, they've got hematomas everywhere. So, funnily enough, most of my dermatology colleagues avoid it. They say, if you want them to bleed everywhere, then let's do that. If you don't, then stay away from it. Now, this was a technique that I brought back from the States from Mark Taylor in Utah, and he basically used tumescent anesthesia. Plastic surgical colleagues here will be all familiar with the use of tumescent anesthesia. What we're doing here is, if I play this video back 1 second, I'll just, show you. I'm using a 22 gauge blunt cannula. Some of you are familiar with this sort of technique with fillers. And I'm putting tumescent anesthesia into the area that I'm going to subcise effectively. And the good thing is it's quite blunt, so it doesn't traumatize the perforators. You don't get too much bleeding. And it also hydrodissects the tissue. It also makes the scarring more evident because the tethering becomes more visible. And the beauty of this is in my anesthetic mix, which is saline, lidocaine 2%, sodium bicarbonate, and adrenaline. The adrenaline works to just shrink off those perforators nicely so that when I subcise and take a few of those perforators out, they don't bleed. And in fact, when we go on to treat these, so these are the probes I use to subcise the area. And effectively, when you put that in, sort of make an incision with a 15 or 11 blade there and just slide the probe in under the scarring and literally just release all that tethering, you literally can hear the sort of tethering popping while you're doing it. no bruises. The next day, he was hematoma-free. So, that's the beauty of sort of the adrenaline and the tumescent mix and hydrodissection. You don't get the awful bleeding that people fear subcision for. So once that's done, I then proceed to resurface the skin. And the beauty of the tumescent is that this deep fractional CO2 resurfacing that was being talked about in terms of being quite painful is actually not painful. She's quite happily sitting through me, ablating 1 millimeter, 1.5 millimeter deep channels into her skin, at sort of 20% to 30% fractional density, doesn't feel a thing. So the beauty of this treatment is that I can do it in one sitting. Now, there was a lot of questioning of whether that's a wise idea, because if you actually disrupt the blood flow to the skin, will the healing be impaired? I mean, my experience is the facial collateral supply is so good that even taking out the perforators under the area that I'm going to resurface with the laser doesn't actually cause too much impairment in their healing from the CO2 procedure that they do afterwards, that I do afterwards. So, this is actually what's going on from the actual skin perspective in fractional laser. You can see here, this is a slowed down version of a scan pattern. So my laser is firing a sort of initial circle that sort of ablates down to the epidermal dermal junction, and then a central channel that penetrates this. In this case, we were doing about 1 millimeter to 1.2 millimeters depth of penetration. And that's that little blowhole you see getting developed in the middle. Now, obviously with fractional laser, you leave intact sections of skin in between. And that really helps with healing afterwards. But the beauty of fractional laser is you can get a depth of penetration to a millimeter. These channels can be sort of made right up to 1.2 millimeters, which really gets down through the whole depth of the atrophic acne scar. Because if you're just touching the surface, so when I used to do chemical peeling a long time ago, sometimes the problem was you can only take it down to sort of papillary dermal, a superior papillary dermal level, and then you don't get the depth you need to deal with the whole atrophic change. Now, this slide is quite important because it shows you what's actually going on in terms of the ablated columns that are being made. Now, when we ablate columns, there's some work done by Dieter Manstein and Rox Anderson that showed that if you keep a column within 0.3 millimeters of width, you will get healing not with scar tissue, but with organized collagen. If you take it above 0.4, 0.5 millimeters, it will heal with scar tissue. So the width of these columns is very important. You start making them very wide, you start healing with scar tissue. But if you start to ablate channels like this that are the right width, you'll get healing with normal collagen, type 1 collagen. So this is what's happening histologically in the skin. So we are penetrating down. Here you see the difference between erbium, YAG, and CO2. The coagulation around the channel is much bigger with the CO2 laser. Here you have much less. The CO2 laser I prefer in Fitzpatrick type 1 to 4 skin because this coagulation actually helps with tightening of the skin. You take collagen to 66.8 degrees and it permanently contracts. So it helps tighten the skin and also helps remodeling in the area around the channel as well. Ice pick treatment, however, is very tough because I try and laser this and I can only improve the superficial appearance. The ice pick scars never go away. So I've now adopted a technique where I basically combine punch excision of many of the larger scars and just excise the tracts and create a flat scar. TCA cross I'm using for the thinner tracts, and I'm getting much better results than I would through fractional laser resurfacing or fully ablative laser surfacing. When you think about what the actual scar is, an epithelial tract, you understand why that will be. So it doesn't look very pleasant for a while. Unfortunately, not very many of the things I do look pleasant for a while. You have to wait for a recovery to happen. This is 90% TCA being administered with, the typical sort of 0.3 mil insulin syringe directed straight into the scar. And this is the end point of that procedure, basically. You see, what's happening here is that TCA is destroying the epithelium in the tract and is giving the scar a chance to heal and contract and potentially fibrose together and close down. So that's the idea behind TCA cross, or chemical remodeling of skin scars. And then I sometimes will, for the boxcar scarring, because it's not too deep usually, opt for a fully ablative method, where I will basically take, the skin down to the papillary dermis. So you see, this punctate pinpoint bleeding is my endpoint, because now you're getting bleeding from the capillary loops in the papillary dermis. So effectively, that's what I'm doing here for the management of these boxcar scars, because those are intradermal lesions. So actually, for many boxcar scars, I start with the fractional ablative to get a good thickness of skin treated with collagen remodeling, and then do the surface finishing touches with the Erbium YAG ablative. So, results. Well, this was a gentleman you saw earlier. This is following subcision and following CO2 and so that's a subcision combined with laser, basically. He was very happy with his new flat cheek, and that is the power of combining things. When I used to try this with CO2 alone, I'd get reasonable amount of the way, but unfortunately I couldn't get to a beautiful flat cheek like that. So that was because nothing was doing anything about the tethering until I subcised. So that was his other side. And you can see the indentation is much improved. This guy, I'm afraid I could only get to this, and it's not a bad result for me. I feel like I would have liked to get him to as close as possible to a normal cheek, but given what we started off with, things have closed down a little bit. Some of those scars have been excised. He was a lot happier, but it's a tough one. It really is. This chap. This was just with the CO2, combined CO2 erbium procedure alone. And as you can see, this is 3 months on after the procedure. And he was a lot happier. Obviously, you can say we're not perfect, but we're a lot better. We're a lot better. Very interesting skin type as well. Obviously, one of the complex skin types that Sam was talking about. This was half Indian, half English gentleman, and I was worried about the level of pigmentation problems that I might get afterwards, but I luckily didn't encounter any post-inflammatory hyperpigmentation. Despite 3 months afterwards, you can still see he's looking erythematous, so that was quite an aggressive procedure. I did tell him that the chances are he was going to get some transient hyperpigmentation, so you just have to manage people's expectations. Now I'm going to briefly just cover a few aspects of other scarrings. I know we're sort of time limited. This is traumatic scar from a laceration from a glass bottle. I was initially thinking that I would subcise this, but when I told him about risks of damage to the zygomatic branch of his facial nerve, he said, no, don't subcise it. It's like, okay. So I thought, well, we'll just treat it with a laser alone. This is a fractional CO2 laser after 2 treatments, and literally, you can see the depth of the scar is much improved because of the new, the beauty of fractional laser that allows you to treat through almost the full thickness of the dermis. This lady has had a reconstruction after operation for breast cancer, and she came to see me because her scar was a little bit hypertrophic and erythematous, which probably, in the fullness of time would have improved. But sometimes people are very sensitive about these areas and want some sort of quicker improvement. Now, this is with pulse dye laser alone, and pulse dye laser, obviously, as you know, is a vascular wavelength from doing the laser module, and it helps with reducing vascularity of scars. So the reddening of the scars is helped, but also the hypertrophic element of the scars is helped by downregulation of TGF-beta1 by the laser, and also the reduction in the vascularity of the scar as well. So just a little bit of brief explanation there. We were talking about keloids briefly as well. And, keloids do present quite a lot in the world of cosmetic dermatology, and effectively we have to manage them in both sort of the NHS setting and the cosmetic dermatology setting. I think we self-select the smaller variety, so not the systemic issues that you were talking about, or the very large ones you were showing me, because those obviously will really qualify for management in the NHS setting. So we talked about the beauties of vascular laser in destroying or reducing the excessive vascularity in keloid scars, but also helping with collagen remodeling due to induction of apoptosis and regulation or downregulation of fibroblast proliferation as well. Now, this is a technique I use combining pulse dye laser with 40 milligrams per mil of triamcinolone. And as you can see here, after one treatment, you get a very good result. Now, the thing is, I completely take on board what Yannis is saying about injection into the deeper part, but I don't know how many of you injected keloids here. Injecting keloids is not easy, because if you're injecting a keloid, just purely injecting a keloid with steroid, if you try and go deep within that keloid, very often you're putting a bit of pressure into that syringe and you're using quite a high extrusion force, because the keloid is just very, very tough fibrous tissue. And if you go, the deeper you go in that keloid, you then get that unforgiving bash, that the syringe just collapses, and you realize, I've just basically infused the surrounding dermis with 40 milligrams per mil of TAC now, and I'm going to come back, they're going to come back and have atrophic changes around their keloid. So one of the beauties of laser is that, if you see what I'm doing here, is I'm literally pre-treating the scar with pulse dye laser. What this does, apart from the things I talked about with TGF-beta1 and helping reducing the vascularity of the scar or the microvasculature within the scar, it also induces edema within the scar. And when you make that keloid scar nice and spongy, it becomes very, very much easier to inject. So here I am now injecting that very same scar, and from a single injection point within the scar, you see how rapidly the scar blanches?
The blanching occurring within the scar. And as you can see by the plunger on the syringe, how easy it is relative to a normal keloid to infiltrate.
Now, I inject keloids sometimes on my dermatology minor ops list in Epsom, and I don't have the benefit of the PDL laser. And I just tell you, from comparing one to the other, I can inject a keloid much more effectively with the addition of my laser than I can with much less risk of dermal atrophic changes due to high extrusion force causing steroid to go outside the margins of the keloid. So you saw that was a very easy keloid scar injection. So there is a little brief run through of the multimodality ways in which laser forms a very important tool in the management of scarring.